My name is Crystal Coens, and I'm Director of Clinic Partnerships and Business Development for MAVEN Project. I would like to thank you all for joining us on today's session, ADHD in Adolescents, A Practical Guide to Management, Part 2. Today's session will be featuring Dr. Najah Musacchio, who's a board-certified pediatrician with expertise in adolescents and young adult health. Ages 10 to 25. She has extensive experience in academic and community-based settings, providing mental health care. She was an attending physician in the Patuxent Family Division of Adolescent and Young Adult Medicine at St. Lurie Children's Hospital of Chicago and an assistant professor of pediatrics at Northwestern University, Feinberg School of Medicine. There, she started and directed the Mental Health and Primary Care Program, providing consultative care for mild to moderate anxiety, depression, and ADHD, and educating residents on how to incorporate mental health care into their future practices. As a staff physician at Girls to Women Health and Wellness, Dr. Musacchio provided primary care and collaborative mental health care, including eating disorder treatment for girls and young women. She was formerly the lead clinician at Uptown Teen Clinic in Chicago. Dr. Musacchio has spoken on many adolescent health topics, as well as mental health care to community groups, trainees, and clinicians. At this time, I would like to turn it over to Dr. Musacchio. Thank you.
Thank you, Crystal. Good morning, everybody. Thank you so much for having me. I'm going to share my screen. All right, can everybody see that? Okay, so today we're going to be talking about ADHD in adolescents, a practical guide to management, kind of continuing where we left off at our last session. There was a bunch of unfinished business there. If anybody has any questions along the way, please put them in the chat and I'll answer them as I'm going. This is a real clinical interest of mine, is ADHD, but it's also a personal interest. Both I and my 3 kids, we all have ADHD. So please understand that any jokes I make are very funny, but also that they come from a place of love. Here are some housekeeping slides. So the learning objectives are continued from last time, which is to talk about starting ADHD medicines in a primary care setting. We mostly covered that last time, but we'll also talk a little bit about that today. Address common side effects and ADHD-related challenges, and describe parent training in behavior management. Parent training in behavior management is a form of behavior therapy, and there's a lot of evidence behind this working for kids who have ADHD. It helps to improve their function. And the way that behavioral therapy works is that it focuses on the behavior, surprise. So what behavior therapy tries to do is like increase the good behavior and reduce the bad behavior. And so it's really kind of skill building, learning, as opposed to theoretical, like I'm going to sit on a couch and talk about what happened to me when I was 2 years old. You can have behavioral therapy directly with the kid. And then you can also have therapy that's aimed at the parents. So the American Academy of Pediatrics recommends that for the really young kids with ADHD, that we recommend this type of behavior therapy even prior to starting medication. And then for like the younger school-age kids, that we recommend it along with medication. And it really gives a boost to the efficacy of the medications. This can be provided in a group setting or individually with parents. And ideally, it's both parents. And it usually occurs takes like an hour and then like once a week, and you go maybe for a few months. There's also some online programs. I gave an example here. This Triple P Parenting is one, and it's $90, but parents can access that online, and it's available in multiple languages in case language is a barrier for your patients. But what else can PCPs do besides say, go to therapy? There's a lot that we can do, and we can really help our families problem solve when they come to us concerned about ADHD related behaviors. We can talk to them about like what was going on before the behavior occurred, what have they tried, and then what is the outcome? And we can counsel families using these behavioral therapy concepts. So we're not counselors, but we can really help do some training ourselves. We can also refer them to online educational resources. And I put a few of them here. Attitude Mag is awesome. It is such a good resource. I think I mentioned it last time, but it's free and it's a website that has like 50 quadrillion articles on many different facets of ADHD. It's really informative for families, for parents, for adults with ADHD, and also for clinicians. They do some medical education there. This is not a paid ad. But anyway, check it out. I usually, for my patients, if I have a new diagnosis of ADHD, I would refer them to this website. And then there's some other basic parent training online on healthychildren.org and children's.com. But clearly this cannot substitute for this really, the actual training itself. And then I put I mentioned YouTube super nanny, Joe Frost. So she's like the old school super nanny from like the early, I think it was early 2000s, but she's got some real oldies but goodies in there about basic approaches to disciplining kids. Maybe not necessarily with ADHD, but with disruptive behavior. Here are some concepts that are really important for any parent, but are especially important when we're trying to help problem solve some of these disruptive behaviors. The first concept is healthy communication and remaining calm. And I think this is probably the hardest out of this entire list, is remain calm. We're talking about parents trying to manage their response to a child with disruptive, maybe physically aggressive, not listening type of behavior with ADHD. And it can be so frustrating. It's very hard not to respond in a big way. And also consider that if a kid has ADHD, there's a really good chance that one or both of their parents also have ADHD. And think about how hard it is then knowing that, and that they might not be treated or diagnosed. Some of these recommendations are even more difficult for those parents. And so that's why sometimes the best treatment for a kid's ADHD is that the parent gets diagnosed with their own ADHD and treated. Anyhow, back to this. So parents need to try to remain calm. And screaming at the kid, it can help blow off some steam, but all it does is ends up amping the situation. It makes it even more emotional. And we're also modeling to our kids that when you're mad, we scream. That's what we do. So making recommendations like, stepping away from the room, walk out, take a few deep breaths, scream into a pillow, squeeze a pillow, and then come back in and try to address what's going on in a really calm way. On a similar thread, parents should also not use physical aggression with their kids. And that again is very tempting sometimes, even if we're not talking about spanking, but just grabbing a kid or like shaking them, you're fighting with your brother again. But again, all this does is amps it up and models the behavior that we don't want. Sometimes some parents, when we're talking about these approaches, might feel like, well, that's how I was raised. Like and I'm fine. And I need to show my kid, like, I'm boss. Like, he needs to listen to me. He's not listening. So for those families, like, you could ask them, well, when you were hit as a kid, what did you think about your dad at that time? They might say like, well, I was terrified of him, or I hated him. And might your child feel the same way? Do you want your child to feel the same way about you? Another approach would be asking them if it works. Like, so, if the spanking or the grabbing, does it seem to work? Because if they're coming to you with a behavior concern, what's going on now is not working. So would you be open to maybe just trying something else as an experiment to see if maybe that approach might work? Parents also need to be specific when they communicate with kids, like in terms of their expectations. So saying, if you hit Johnny, you're going in timeout, as opposed to don't hit Johnny, or are you going to hit him? Don't hit him. Things like that. Like you want them to understand clearly what will happen if they engage in a certain behavior, and then also following through on what you say, which is also hard. A next concept is positive reinforcement. So really focusing on the good of the kid. I know that's reductionist with like good, bad, but I think it's easier to communicate using those terms. But you want to even notice the good. So if you see your kid doing something and you're like, oh, like I saw you were playing so nicely with your little brother. I saw him grab the truck from you and you were very calm. That goes a long way. Parents can also do something more overt, like instilling a reward system. You can have a token system for every time you do this, you get a sticker or a little cotton ball or a mark on a paper. And then once you get so many, then we're gonna, do something. Parents should also ignore the mildly bad because sometimes giving those types of like little things that kids do, giving it oxygen and that negative attention can actually end up making that behavior persist. And then finally, if there's actually negative behaviors that we don't want kids to be doing, like physical aggression, there needs to be consequences for that. And so depending on the age, this could be a timeout or it could be removal of privileges. And then next, another concept is structure. So parents want to have rules in the house that are known by everybody. And sometimes when we are trying to kind of like improve the home situation in what's going on, the family might need to have a meeting where everybody meets and we talk about the rules for everyone. And it would be good if the families would kind of approach this as like, we're all working on screaming, or we're all working on hitting. So that it's not aimed just at the kid with ADHD, but it's really like, this is important for our whole family. This is also a spot where like, it could be a good point to open up a discussion too, if you're talking about behavior, is like, what are the rules in your house? And if parents have some difficulty thinking about it or expressing what the rules are, then that can be a clue that maybe the kid doesn't understand the rules, or maybe the rules change a lot and it's confusing. Also having a schedule, so there's clear expectations about this, and then this happens, then we're going to do this. Especially for kids with ADHD who have trouble around transitions, it's good to give them a warning, like your friend is going to be picked up in 15 minutes. So in 15 minutes, we're going to need to, wrap things up and start getting ready for bed or whatever. And then make the structure consistent across multiple households or babysitters or grandma, making sure that everybody has the same understanding about what is allowed and what is not allowed. Then we can also help families to prevent problematic behavior by helping them identify what's happening before this behavior starts. Like maybe it's like, oh, it seems that whenever he stays up past 9:30, the things really kind of like fall apart for him. And so trying to figure out what the contributing factors are and then eliminating them. Also, spending some positive alone time with your child. This goes so far with any kid, but especially when a kid has been struggling with behavior issues, they can start to see their role in the family as the bad one. And also the parents end up losing out on that really positive, fun relationship they have with their kid. Like they might say like, I have not laughed with my son in, months. So kind of like protecting some time, hopefully every day for like 10 minutes would be a really good goal. So it doesn't have to be some extravagant thing. just spending time where all you're doing is putting your attention on the kid and you're doing something that you enjoy, even if it's like playing a video game together or talking about school or having a snack together, whatever it is, it's like you're just focused on the kid. That's super important for a parent too, because it kind of reminds them of like, oh, like here's the joy again I have with my child. And it gives the kid positive feedback. And then finally, you can also discuss these basic foundations of good behavior and of health. So is the kid getting enough exercise and playtime on their own? Kids with ADHD have so much physical energy to blow off. They need to blow off that steam. Otherwise, they're going to need to go into blowing it off in other ways, like hitting their brother. Sleep is very important too. So finding out how much sleep the kid is getting and if are they sleeping through the night, and then nutrition too. So now I was going to go through some, oh wait, I see something in the chat here. Oh, except I cannot see it. I don't know why. Oh, here we go. How do you squeeze this all into a 15-minute visit using an interpreter? Magic. No, it's impossible. There's no way. I mean, if you if someone is coming in with behavior issues and you're going to diagnose them with ADHD and then talk about medication, there's no way that can be done in a 15-minute appointment. So you would need to prioritize, and the family would need to come back multiple times, unless you're able to extend the visit time. And with mental health, that's one of the challenges in primary care, is carving out time that is necessary to do an adequate job with some of these concerns. But if you're talking about just a behavior issue and the kid is on medication, I feel like that can be done in a 15-minute appointment. Okay. Oops. So I'm just going to run through some, or any other questions? I'm going to go through some like cases, and they're going to be just common complaints or concerns that people have who are on ADHD medication. And I'll ask for your input on them. The first thing is, I am so behind in homework. So this is a kid, a teenager who you've recently diagnosed with ADHD and you've started them on medication and their grades have gone into the toilet, and they're like, oh, I am so far behind. Like, how do I even catch up for the rest of the school year? Does anybody have any ideas of what they would say or advise this family? Daily planner, check boxes. Yeah, great. Get school teacher involvement. Excellent. Yeah, definitely the school teacher involvement is very important. If you're going to diagnose, when you're diagnosing this patient, you would want to write it in a brief letter, just describing the date of diagnosis, what type of ADHD they have, what assessments did you use, medication, and then I like to write accommodations, which may be helpful, are preferential seating, use of a fidget, extended test time 1.5 times, and then, leave it to the school to actually make those assessments. The other thing I might write would be, this, as I work with this patient on medication and on treatment regimen, I would appreciate any patience and understanding you have as she is trying to catch up with her academic work, something like that. And then that might allow them to have a little bit of breathing room. Consistency, yeah, just kind of like getting at it. Minimize media use. Okay, good. So setting up some kind of expectations for before you are able to go on your phone, you need to do whatever homework. What resources, the question is, what resources are there for parents when school is not following recommendations made by neuropsych evaluation? Oh, wow. Okay. that is very hard. You know what? I would have to think about that. If they're not, if they're, I mean, first of all, if you can get involved as an advocate and even just writing a letter or maybe talking, I think that could be helpful, because if it's coming from a medical clinician, it might carry more weight. You also sometimes have to think critically about what's going on. Is it possible that the school has information that that neuropsych doesn't? I mean, if they're with the kid all day long every day, that maybe their opinion might be a little bit different. Like, I would try to review both of the recommendations and talk about it with the family if possible. Yeah, I don't know. I would imagine that there's some kind of advocates who work in this, or if it needs to get up to at the legal level, like an attorney involved. Those are my thoughts, I mean, off the cuff about that. Okay, so executive function issues are extremely common with ADHD, and kids often, and adults often, become so overwhelmed by everything they need to do that they end up becoming paralyzed with it. Like, I have so much to do, I don't even know where to begin, so I'll begin nowhere. And they procrastinate. And you end up procrastinating things that are even like, once you do them, you're like, why did I put this off? This is like idiotic. Like, I did this in like 1 minute. So some advice you could give to patients talking about this are focusing on the feeling of being done as opposed to the feeling of starting. Like, I know you're going to feel terrible, like sitting down with your history book, but how good are you going to feel when this is all over? And then, like some of you mentioned in the chat, just talking about basic executive functioning skills, like planning ahead, thinking about, like, if this project is due Friday, I'm going to put it in my phone. Like, where do I need to be Wednesday? Where do I need to be Monday? I mean, we all have these computers in our hands, and kids don't tend to use the scheduling function on them, but it can be so easy to do. Also, I think it might be helpful to use time-based planning, like when you have a homework from a bunch of different classes at night, to think like, I'm going to do half an hour of history and then take a break for 10 minutes, and I'm going to do half an hour of math, as opposed to, I am going to do my math homework or do history. That feels a little bit more overwhelming. And really, once a person starts sitting down and actually doing it, that's the hardest part, is the initiation of the task. And if I'm doing my math homework and then I start to think like, oh, I still have to do history, I still have history homework, remind yourself, this is my math time. I will worry about history when I'm on history. And so kind of like dividing up your evening in terms of time can also help with anxiety that arises. And then school accommodation. So we did talk about that already. Okay, so this is a question coming from a provider. How can I be sure he's not going to sell his Adderall that I am prescribing? So what are your thoughts about that? I know this is very, very common concern among clinicians. But what we want to do is minimize the diversion risk while promoting access to care. So we cannot put the diversion risk to zero unless we don't prescribe stimulants. There's always going to be a risk. And if we didn't prescribe stimulants, that would be awful from a public health standpoint, because stimulants have so much data behind them that they are effective in improving function and really altering the trajectory of a person's life. So we want to make sure that we're promoting access to care. We don't want to set up too many barriers for patients. The first thing that we'd want to do is make sure that we have an accurate diagnosis. That is probably the most like protective element of this. If the person really has ADHD, then, and they can only have a limited amount of stimulants every month, then they're not going to want to sell or share their medication because they need it. So making an accurate diagnosis in a older kid can be a little bit more difficult, but it can help with accuracy if you're getting input and history from a parent or getting a Vanderbilt filled out by a teacher or a coach, getting input from the school, like someone else corroborating what the patient is saying. Also, I counsel all families on sharing and selling the first time I prescribe medications. And so I say it like, I tell everybody this because I don't want them to think I am like profiling them or that I'm picking them out, that they might want to share or sell it. I say this to everybody, but this is a controlled substance that I'm prescribing for you, and I'm prescribing it under my license. And so I'm trusting that you're going to use it for your ADHD. And sharing it or selling it is illegal. It can be a felony. And if that were to happen, I could no longer prescribe you the medication. Also, at follow-up appointments, ask about use. So if someone comes in and they're like, oh, I need my Adderall refilled. Okay, great, here you go. Like we want to ask more than that. We want to know, how often are you taking it? What time of the day are you taking it? How long does it last? And then we want to make sure that makes sense, like physiologically, when they're taking it. And does it make sense with how often they're asking for refills? If you prescribe a long-acting stimulant or a non-stimulant, it's less likely to be abused, meaning it's less likely to be snorted or injected. And in the case of a non-stimulant, like those are not abused pretty much. Something like Vyvanse, which is now generic, lisdexamfetamine, which is a long-acting stimulant, it's actually a prodrug. So it can only be activated if you in your gut. So that cannot really be snorted or injected. But of course, it can be shared and other people can take it. And then it's important to know about your local laws. So I know I saw in the beginning, there's like a bunch of different states, people from different states here. But it's important to understand and look up, what are the laws in your state about prescribing controlled substances? What are the limits? For example, in Illinois, where I am, you can prescribe up to 3 months of a 30-day supply ahead of time. So as you're seeing patients and getting them on their medication and spreading out the appointments more and more, you need to think about, like, how long will I go comfortably and appropriately before I need to see a patient in the office again? And so for me, that was usually a 3-month period that I would need to see them again. But we don't want to force people to come in every single month when it's not medically necessary. So hopefully you can take advantage of whatever advanced prescription laws there are. And then of course, like here in Illinois, we have this prescription monitoring program where it gives you some assurance that a patient is not filling my Adderall XR and then going to somebody else and then filling another Adderall XR on top of that. And then you can ask about substance use as well. Someone who is using cannabis, let's say, once a week, I would argue that that might even be more of a reason that I want to treat them with a stimulant, is to hopefully help manage symptoms that they might be self-medicating. But if someone actually meets criteria for a use disorder, then that's a situation where they would probably need psychiatry instead. All right, next is, I lost my Adderall bottle. On a similar vein, do you have any thoughts about what you would do or what you would want to talk about with this patient? Okay, so if someone says that their Adderall was stolen, they need to file a police report. And if it was lost, you want to find out what was going on exactly. And usually, like, my approach to like a situation like this would be like kind of like once I'll accept, like, this can definitely happen. I mean, we're treating ADHD, and that's like even part of the diagnostic criteria is like forgetting important things. So it's not like so rare that somebody might lose this bottle, but you want to talk to them about how serious this is as a controlled substance, and that you can try to write a prescription, but if they're, do the prescription monitoring, and even if they report that it was lost, their insurance might not cover it, they might have trouble getting it filled. So talking about how to prevent this in the future. They should not be walking around school with a bottle of Adderall. If they go somewhere overnight, they need to travel with a limited quantity, like a pill box with like one in it, not the whole bottle. And if they live in a group living situation, like a dorm, their medication should be in a locked container, and you can get those on Amazon. Also, I recommend that kids not even tell their friends that they're on it or that they have it. Not because it's, embarrassing or something, but because it makes it less likely that they're going to be asked to share or sell it. And it's clear that the vast majority of kids have been asked to sell or share it, even from a pretty young age. Okay, I'm just looking at the chat here. Would also ask about weekend use, have parent, school, nurse dispense the med, and pay attention to the controlled substance state database info. Okay, that's great. Yeah. And I'm assuming this is in response to our current case that about having the parent dispense the medication. Yeah, having the parents take it over. And talking about like, if this happens again, like then I might not be able to prescribe it anymore and might need to have you see psychiatry instead. He started skipping lunch. So this is a kid that, a young adolescent that you just started on Vyvanse, let's say a long-acting stimulant, and they come back in 2 weeks and they're saying that he's been skipping lunch. What are your thoughts about this? Okay, somebody wrote increased caloric intake at other meals. That's great. That's good. Whoops. Okay. Well, we definitely want to monitor the weight at every follow-up appointment for patients with ADHD, and we want to be looking at their growth chart. It's not uncommon that when someone first starts a stimulant, especially in a teenager, that their weight might dip a little bit. And then usually though, it comes back up to where they were before, or it might just stay steady at a little bit of a lower level. But you have to think about a patient's age too, when we're talking about weight and nutrition, because for younger kids, who are still growing, it's not even normal for their weight to be continue as opposed to like increasing. So that's a little bit different from a teenager who maybe is like at the end of their growth spurt, or for a girl, like they've already stopped growing. And if you're on a stimulant, a long-acting stimulant like Vyvanse, the medication reaches a maximum level in your blood around lunch. So lunch is usually like the worst meal of the entire day. And usually the side effects that you get from stimulants that are physical in nature, those tend to improve with time. So it's like the worst the first day, a few days you're on it or a week, and then your body kind of gets used to it a little bit. So since this patient was just started on it, if his symptoms of appetite loss are mild to moderate, and if his weight loss, maybe he lost a little bit, but it's not too bad, you might want to wait it out a little bit, especially if he's having any kind of improvement of his symptoms with the Vyvanse. But you want to follow it and see how it goes. And then, as someone mentioned in the chat, nutritional support in the meantime. So taking advantage of the times of the day where the medicine is not so high, it's so high of a level in the blood. So we want him to eat breakfast every morning. In a teenager, good luck. No, you want to talk to them about strategies to make it easy, because we all know mornings are like totally crazy. So if he can put a granola bar in his backpack, like do it ahead of time the night before, or if it's a bagel with cream cheese, put it in the refrigerator, and then you can grab it in the morning, or whatever he wants to do to try to make that routine easy. Sometimes kids who are on stimulants, it's more palatable for them to have multiple small snacks during the day as opposed to a big meal in the middle. So they could bring things like string cheese or beef jerky to school or to activities. And then having a large after school snack. That's a great time. That's like when you get home from school and like the stress of school is going away and the serum levels are on the decline. That's a nice way for kids to relax. And then finally a late dinner or a second dinner. So by the time that if they're on something like Vyvanse, which could last, 14 hours, that medicine is like coming out of their system or maybe around dinner time. So they might eat then, and then they might want to eat again before they go to bed. The issue that we might get into with patients that can be more difficult is when the side effect is great, but they're having such a good improvement in their symptoms with that stimulant. And for those patients, there has to be a discussion about risk benefit. Like the only way that you can continue to take this medicine, if this is the one that you want to be on, is like you're going to have to eat even if you don't feel hungry. So your body is your body is literally hungry, but you're not recognizing those signals. So like overriding that. Okay, let me look in the chat. Okay. Mary asked, what is his weight? Is it a result of med? Great. And I'm going to go to the next slide on that. Have them eat after school. Make sure they're taking it after breakfast. Yeah, that can help too. That's a really good point. I was told Concerta affects appetite less than others. Do you agree? I'm not sure about that, about the data on that. I mean, just in terms of, I'm just trying to think like anecdotally. I don't have any anecdotal evidence either, like in my experience, but that's something I'll look into, and maybe I'll talk to Crystal about how we can let you all know about that. Generally speaking, like if you're having such a bad effect on appetite with one stimulant and it's not giving you enough of the benefit, like I would go to the other stimulant class. Okay, and then the next slide was, whoops, spoiler. Okay, the next slide is he's lost so much weight. So this is someone who's having significant side effects from their stimulant. And so we would want to look at the growth chart. One thing to keep in mind about weight loss in teenagers who are on stimulants is that sometimes, if it's not a huge amount of weight, sometimes it can represent an actual improvement in some types of eating behaviors. So sometimes people with ADHD, just in the same way that they're like hyperkinetic and always moving and like fidgety, that can manifest as eating and like always wanting to kind of put something in your mouth, and like how that helps you even concentrate. So talking to patients about that, because if they're on a stimulant and then that type of non-nutritive eating improves or goes away, then that they might actually have healthier eating habits, if that makes sense. Also, when there is a significant amount of weight loss, you want to make sure that the person is not developing disordered eating patterns. Like sometimes this is how people kind of accidentally fall into an eating disorder, is that they started losing weight on a stimulant and then everybody starts saying stuff, positive things to them, and then they just keep going. So talking to patients about body image, regardless of gender, keep that in the back of your mind too. So, some clues to that might be someone who seems to be taking like a higher dose or a dose with side effects, but they still want to take the medication, or they are taking it, let's say that they want to take like a booster dose like every single evening, although mom is like, I don't really know why, like she doesn't really need to use that. Those could be clues. And okay, so then if someone persists with this as a significant side effect, no matter all these other behavioral changes that you've recommended, then you're probably going to end up switching the medication, because you could drop the dose, but then it's just not going to be as effective. And there's a reason that you probably went up on the dosage already. So I would switch to the other class of stimulants. One other option is you could add cyproheptadine. They can take that every single day. Cyproheptadine is a somewhat sedating antihistamine that can be associated with weight gain and can help people's appetites. Okay, and then I have a comment here. about, I've seen, however, obese children who continue to gain weight despite stimulant use. Any suggestions? Well, and let me tell you, in my experience, it seemed to me that once you are at a proper stimulant dose that was helping your ADHD symptoms, there was usually almost always somewhat of an effect on your appetite. Even if it was mild, there is something there. So for me, it was rare that I would get improvement of ADHD symptoms without the appetite side effect. So if it's not affecting their appetite at all, I'm actually wondering if maybe kids, if these are underdosed, the children that you're talking about. And so I would definitely want to make sure that their function has improved. Vyvanse, that can help with certain types of binge eating in adults. But it is not FDA approved for that in kids. Of course, like any medication that affects your appetite, it won't necessarily affect kind of like disordered eating patterns. Like it doesn't stop you from still eating. So I can see how if someone is eating maybe for stress relief as like an unhealthy coping skill, that might continue despite being on the medication. She is so cranky after school. Okay, so this is like a 11-year-old that you've started on Concerta, let's say, and they come back for the 2-week appointment and mom says like, oh man, after school, she gets back. She's like, even cries sometimes. She's like, just very moody, not happy. Does anybody have any thoughts on this one? Okay, so managing, oh wait, someone has a comment. Noontime dose. Okay, do you mean adding and not a short acting? Immediate release at noon. Okay, so this patient, okay, I think I know where you're coming from on this. So if this patient is taking Concerta every morning, I mean, that should be lasting like probably 8 hours, maybe a little longer. So she takes it at 7 a.m. It's lasting to about 3 p.m. And so this sounds to me like it's probably, it could be rebound effect from the stimulant. And that can happen as the stimulant is like leaving your system. Sometimes kids can have this like rebound crabbiness and irritability, rebound hyperactivity. There are some other things that can contribute to this too, is that managing your symptoms of ADHD all day at school can be really stressful. You're like trying to rein it in, and then you come home and you just want to let it all out. It can also be a little bit jarring for kids, like when you start a stimulant and now you really are in better control, and then that control starts seeping away. So what you can do for these patients is recommend a relaxation period after school. And for some kids, they're going to want to be by themselves and just like, I just need to like not talk to anybody. Let me just like chill out in my room. And other kids might want to run around and play, but something where they can kind of decompress a little bit. Also, give them a snack, because this kid who just started Concerta, they might not be eating well at lunch and they are hangry when they get home from school, and maybe they don't realize it, but that can be part of this relaxation time. Make sure they're sleeping okay. Talk to them about how much sleep they've been getting since they started the medication. And then if all of that, you kind of worked on all that, you could consider, I would first go up on the morning stimulant before adding another short acting. So if you increase the morning stimulant, sometimes that can make it seem like it's lasting longer, because like the serum levels are going to stay above like whatever level for a longer amount of time. And so that can sometimes smooth things out a little bit. Or if you want to add oh, you meant afternoon. I just see the comment, Joseph. Okay, yeah. So afternoon booster dose is also an option after trying this other stuff. So if the person is on Concerta and we're happy with how her symptom control is during the day and like side effects during the day, but then there's just this crabby period, you might want to add on a low dose of an afternoon booster when she gets home from school. And that can help with some of this behavior in the evening. Another option is guanfacine. That can also every day. So that can also help this hyperactivity as well. And then sometimes too, like if you've tried different things, you might need to maybe try the other class of stimulants too. He's not sleeping well. So this is a patient, same scenario. It comes back like 2-week follow-up appointment when you've just started Concerta, let's say, and is not sleeping well. And it's a 15-year-old. I'll add that. So this, again, this is one of those other physical somatic symptom side effects of stimulants that can just get better with time if we wait around a little bit. You want to make sure that he's taking the medication at the appropriate time. So for a long-acting stimulant, they need to be taking it in the morning before they go to school, because those are going to last 10 hours, 12 hours, 14 hours. And so that way it should be out of your system before you go to bed at night. But despite it being out of your system, these stimulants still can interfere, especially with sleep initiation. So initially falling asleep. It can make kids a little bit more like able to stay up late if they allow it, basically. Any short-acting stimulants, those should be taken ideally by like 4 p.m. after they're doing like a long acting. So some people, they can tolerate later than 4 p.m. They can do a 5 p.m., 6 p.m. Ritalin or Adderall booster. Other people are more sensitive to that, and then they end up not being able to fall asleep. So think about those medication times. And then you want to talk to the family about what the expectations are for homework and phone and bedtime when they're on these stimulants. The goal of the stimulant is not to wire somebody so they can tolerate not getting any sleep and like staying up on Instagram. It's so that they can get their homework done more efficiently and then go to bed earlier. So what are the rules in the house about getting your stuff done before getting on your phone? Okay, now there's a comment in the chat. I've seen some clinicians use clonidine or trazodone at night for sleep. Thoughts? Yeah, so clonidine, personally, I have used these very infrequently. Clonidine is also a non-stimulant that can be used for ADHD symptoms. So that's why that might be a good option. And then trazodone is an antidepressant that actually is used more for sleep, especially in someone who has like depression. So yeah, I haven't seen it get to that point, I guess, is my take-home message. When you're talking about a side effect of an ADHD, of a stimulant, like I'm hesitant to add on another medicine to treat one side effect. Like I would first want to try working on what I'm doing to cause this problem and making sure that maybe I'd want to switch the medication or talk about behavioral changes to try to get them to go to bed earlier. And I would see this more as like an intolerance instead of treating it with something else. But actually, and as opposed to these, I would probably do guanfacine before I would do clonidine. Clonidine can also be dangerous in an overdose, very dangerous. Guanfacine can as well, but not quite as hazardous. So I might go with guanfacine to help with the sleep, which is also, FDA approved for ADHD. Okay, I'm going to wrap this up so we can go through questions. Okay, and then Joseph wrote, completely agree. I found it is critical to talk about sleep hygiene when treated for ADHD, 100%. Kids with ADHD and adults tend to be night owls. They might be wired that way, but then also some of this has to do with procrastination and like falling into a black hole of, some random topic that you get really into. Sleep hygiene absolutely needs to be talked about for these kids. Thank you for bringing that up. So picking nails is another common concern. And just briefly here, fidgeting can actually help people sometimes when it's used for focus, but it can also be a sign of anxiety. So for kids who are fidgeting and doing something, sometimes even like picking at scabs on their skin or picking at their hair or twirling their hair, we want to make sure that they're doing something that doesn't disrupt other people or cause bodily harm. So sometimes kids can use like not even a certain ADHD ring, although they make those, but like rings that you can twist on your finger or like a bracelet that you spin or pen twirling, although that can be annoying for people around you. Okay, and then I think this is, oh, I'm almost on my last slide. Or what, Crystal, did you want me to stop? Is there like a hand raise or what do you think?
You're answering the questions as they're coming through. We have about
Good.
5 more minutes, so you
Okay.
can continue on, and I'll
Okay.
stop you probably about 2 minutes prior to.
Okay, cool. Thank you.
Mhm.
Okay. Parents say, so this kid has been on, let's say, Concerta for a few months, doing much better in school. This is a 14-year-old. And then the parents say he has become so serious in starting medication. He focuses great, but we miss his spunky personality. Does anybody have any thoughts on that? So this comes down to a risk-benefit discussion with the family. Like when we prescribe stimulants, we're not looking for zero side effects. We're looking that the family feels that the benefit is worth the side effects. And yeah, stimulants can make people more serious. It can quiet down the silliness. It can absolutely make a little bit of a change for a person. Now, if a person was really struggling in school and now their grades are really high and they're so happy about that, then for them it's worth it. But sometimes it's unwanted. You know, when you miss that silliness or the joking around, which can also border on, disruptive in your classroom. So some options would be they might want to skip or take a lower dose when they're doing creative activities or on weekends. But really talk through this with the family because ADHD doesn't just affect your school, it affects how you interact with your friends. Are you interrupting them? Are you even paying attention to what they're saying? When your mom asks you to clean your room, are you actually going to go clean your room or is she going to nag you for 3 hours? So if you're going to try something like that, they need to kind of keep an eye out for that and see how it affects their lives. You could think about lowering the dose, period, every day. And you could think about switching a stimulant class or switching to short acting. And you could switch to short acting maybe on weekends, as opposed to the long acting. Okay, and this is the last slide. So I don't want her to use, this is the mom saying this. When you want to start ADHD medicine on a patient or you're recommending it. I don't want her to use medicine as a crutch. I don't want her to be on something to start something she'll be on the rest of her life. As you think about that, I'm seeing Joseph wrote, how do you combat internet misinformation regarding stimulants? Oh my gosh, this is like, that's such a good question. That is so hard. I mean, first of all, people are reading stuff on the internet because they want to learn. It's like, I get it. Like we all do that. So you want to make sure the patient feels comfortable with you talking about it. So we want to try not to be judgmental. Sometimes it's very hard, but you really want to hear like, so what did you read about? Tell me about your concerns. Sometimes when there's a disconnect and like someone is not, maybe you're making recommendations, but like they're not doing them, like this could be why. And maybe they're too shy to share it with you. But definitely ask about what are they thinking or like where do they see that? And in the end, I mean, it's going to just come down to the relationship I think that you have with your patients and making sure that you're listening to them and then talking to them and sharing them about your medical experience and knowledge and how that might not be true, what they're seeing online. Okay, so I don't want to start medication. This is such a common concern from parents about all different mental health medications. I would say that our treatment goals are not to change a person or fix them. We want to help them reach their full potential. And with ADHD, it's like wearing glasses. So if I can't really see the blackboard and my mom buys me glasses, I'm not addicted to my glasses. My glasses are not a crutch. Like, this is something I need to use so that I can reach my full potential. And medication also helps make these behavioral strategies, like what the families are working on in terms of discipline, what the school is going to do for support, more effective. Like, a lot of kids, especially the ones who are over 12, we can do all the support we want, and we're not going to get the improvements we're going to see with medication. There is also a risk to not treating. There's a bias in us that we tend to see the risk of us doing something. We weigh it more heavily than what is the risk of us not treating. So patient having trouble in school, what is that going to mean for them the rest of their lives, or to their self-esteem, or to, their relationships with their family? And then finally, the best thing, not the best thing, one of the good things about ADHD medications is that they're in and out of you in 8 hours or whatever it is. So try it, a low dose. If you hate it, don't ever take it again. It's not like an SSRI that's like building up in your system. We have to wait weeks, months. This is like, it is what it is. So I really encourage families to try it as an experiment. And that way, if you don't like it, we're done. Like, you don't need to do it anymore. So I put some resources at the end. This is more from the last talk, but Attitude Mag, the AAP Clinical Practice Guideline for ADHD, ADHD Medication Guide, and then the Vanderbilts. And that's it. Okay, 801.
Wow, thank you so much, Dr. Musacchio, for that wonderful presentation. Always enlightening to get information about ADHD from someone that actually experiences it. So we're getting it from the horse's mouth. So this
Yes.
is good information for myself as well as our participants. I hope each of you enjoyed our presentation. I just want to remind you all to complete the CME survey that will appear in the tab once you close out the webinar so that you can get your CME credit. And I hope everyone has a wonderful day.
Thanks, everybody.
Thank you. Bye-bye.